On March 5, 2020, the Faculty of Medical Sciences Teaching and Research Complex, the UWI campus, held a conference entitled COVID-19 Pandemic Preparedness. Speaking on hospital preparedness is Dr. Carl Bruce.
I just want to share with you what has shaped our strategy over the last few years. So I'll step back a bit and show you what has been the thought process behind our preparation for not just COVID, but for what I see as an emerging challenge for us in the medical sphere. So, as Professor Christie would have said, on the 30th of January 2020, the International Health Regulations Emergency Committee of the WHO, and announced by the Director General himself, declared a public health emergency of international concern for the novel coronavirus, now labeled COVID-2019. The Ministry of Health on January 31st issued travel restrictions that you know well and which they will share with you. And the University Faculty of Medical Sciences and the University Hospital had a public awareness and education campaign starting on the 5th of February with CPC organized by Dr. Alice Nicholson, the head of microbiology and the head of infection prevention and control at the University Hospital of the West Indies here at Mona. We subsequently had staff meetings on the 11th and 12th for both the morning and afternoon shifts, and we started our formal task force meeting just prior to the announcement on January 28th. And then we had a joint workshop with the Ministry of Health on February 13, 2020. So what led to this? I want to take you back a little bit through our thought process. Many of you would have been in this room a few years ago, just prior to the Olympic Games in Brazil, when the Zika crisis, which started about March of 2015, was in the public sphere. And at that time, we had a discussion at the hospital, but we took note of this slide. And if you notice, beginning in 2007, you can see the progression, transcontinental progression of Zika, all the way across from Micronesia, French Polynesia, and worked its way across into South America, and then up the Central American coast, and many of you here know the consequences of Zika. But you will recall prior to that, in 2013, the challenge we had then was chikungunya. And if you think about it, before that, in 2012, it was MERS. You could go all the way back to 2003 when you had SARS. Now, if you interspace on this slide, do I have a mouse? Or a pointer if someone has it. If you follow the progression on this slide, you could also put the public health concerns for H1N1 in. You could also put in prior to MERS other emerging diseases that have caused significant, I would say, concern among healthcare workers. So for us, it was becoming more and more frequent and more concerning, and you would say, maybe it's a different disease, different virus, but in healthcare delivery, you have to think of the overall picture. Many people were very concerned, obviously, about Ebola, and up to 2016 and overlapping Zika, Ebola was finally declared controlled in 2016. But at that time, we were just overlapping with Zika and heading to the Olympic Games in Brazil. And Ebola, as you realize, was quite significant in terms of the number of deaths caused. And a lot of preparation was done across the island by several of our institutions then. And fortunately, we did not have to isolate a case. But I also want you to share in this graph that we have taken note of. Look at what has happened with air travel over several decades since the 1930s, and look at where the graph is now and the trend of the graph. And if you were to plot the spread of diseases, as I just showed you against this graph, you might say there might be a correlation, and the scientists in the room may be able to expand on this more, between how quickly we move across continents and how easy we move across continents and what's emerging in terms of these different disease processes. So we therefore, with this strategy, had a reset in 2018. After about 2 years of planning or so, Dr. Nicholson came back to us with a proposal. We discussed it with the Universal Service Fund, and with a $31.8 million grant, we opened the first infection and prevention control department in this part of the Caribbean in January of 2019. I think this was an important step for us in our thought process and preparation, because as I said, you will be able to dissect the details of COVID, but as a healthcare manager, we had to look at what the trends were year by year and what was happening to us. Because if every year you go back and you say, okay, I need a budget for this crisis that I'm having now, at some point in time, somebody's going to say, well, you seem to be having a crisis every year. I don't think we can say that we are responsible for it, but it's certainly where the planet was going. Fortune magazine did this possible or probably spreading route for COVID 2019. And you can take the slide, or I'll share with you, and you can see based off this slide that, as Professor Christie just said, it's a matter of when. So therefore, based off the trends that we have in travel and based off the trends that we have in global business, as a hospital, we have to make sure that we take into account in our planning what happens. I will not spend much time on the timeline of the coronavirus. I think Prof has gone through that with you carefully, but you can see the number of cases have been increasing significantly, and these are the numbers as of this afternoon, March 5th. If you look at the mortality of COVID, it's something that we have had to use to determine at our task force what our strategy is going to be. So Prof pointed out earlier that there are no deaths recorded in children under 10 years old, under 9 years old, but look at the mortality in the group at 80 and above. It's at 14.8%. So you can see there's a significant contrast between the extreme of ages. This is a graph that shows the confirmed cases and the number of deaths. So while we have a concern and we're going to prepare, we also have to take into context how we're going to manage and what we're going to deal with it, because both the number of confirmed cases and the deaths help to form part of our strategy. So if you compare the novel coronavirus and you compare major viruses since 1976, if you look at the fatality rate, 40.4% for Ebola, SARS we mentioned in 0203, 9.6, Middle Eastern respiratory syndrome, 34.4, COVID 3.4. I'm not asking you to be comfortable. I'm just saying that we have to take this into consideration in our strategy, and we also have to look at who is being affected as we deploy our resources. And so the task force has also taken the fatality rate into concern. So we started, as we said, on January 28th, 2020. We wanted to implement a strategic preparedness and response plan, and we wanted to reduce avoidable deaths and illness at our institution. So we have a committee which is chaired by myself or one of the infectious diseases specialists, and it goes across many different departments, as you can see, but we involve infectious diseases, virology, the new infection prevention and control unit, occupational health, which we now have at the university hospital since over the last 2 years, obviously our public health team, but our maintenance team has played a significant role, waste management, and our security teams. Our general agenda, it looks like this: isolation, waste management and disposal, personal protective equipment, staff awareness and education, staff and allocation for COVID 2019, that's a significant challenge, management of COVID patients, communications and public awareness. I think we have to give good information and timely information, but the best information we have, as Prof pointed out. And we also wanted to look at our laboratory capabilities and our policy regarding our own staff. As Prof showed you, there's a 0.4 fatality rate among staff. Our tangible gains to date, we have a step-by-step operating procedure manual with the guidance of staff and healthcare workers directly involved in the management of the COVID-19 patients. We have improved upon our design of our isolation unit. So we have an isolation unit which is, as you know, located in our emergency medicine division. But 3 years ago, we also designed and opened 2 additional negative pressure isolation unit within one of our intensive care unit, and those rooms are also functional. So we have 3 high-level isolation units, but we also have a significant strategy should we have more cases beyond needing just isolation. I will mention why isolation goes with diagnosis in a moment. We've also, as you've seen based off the first slide, improved our staff awareness and sensitization. We have had several general staff meetings, and we have daily infection prevention and control training. We have now, as of today, trained between 60 to 70% of the 2,500 staff at the University Hospital of the West Indies. And we have continued to improve the diagnostic capacity in the National Influenza Center, and Dr. Sandra Jackson will speak to you a little bit later. We have designated treatment sites for COVID-19 patients deliberately in the hospital, and we know that we're a referral site for other hospitals who will need support, and we plan to give that support. What type of patients will we manage at the University Hospital of the West Indies at Mona? Well, obviously confirmed cases of COVID-19 who have tested positive on a validated SARS-CoV-2 nucleic acid test, and we'll tell you more about that later on in the conference. But also cases referred from other hospitals who need support, Dean, and those who may be referred from quarantine sites, who are holding Jamaicans who are landed, but who have been in countries who, within the last 14 to maybe 28 days or so. Dr. Webster will clear that up for you. But any of those patients who get sick, we are also prepared to take those patients. And you can see from here, Professor Smichael, Minister Tufton, and Dr. Michelle Hamilton from the National Public Health Lab toured the National Influenza Center here at the University of the West Indies, Mona, on February 17th. And we have significant capacity apart from this. I think we have 2 to 3 of the machines. The test has been validated, and at least 7 people were trained when at the time of this visit to the University Hospital. The cases are subdivided into 3 subcategories. A patient with acute respiratory illness, fever, and at least 1 sign or symptom of respiratory disease, example cough, shortness of breath, and with no other etiology that fully explains the clinical presentation, and a history of travel to or residence in a country or area or territory reporting local transmission of COVID-19 during the 14 days prior to the symptom onset. B2, a patient with any acute respiratory illness and having been in contact with a confirmed or probably COVID case in the last 14 days prior to onset of symptoms. Category C, a patient with severe acute respiratory infection, that's fever and at least 1 sign or symptom of respiratory disease, example cough or shortness of breath, and requiring hospitalization, and with no other etiology that fully explains the clinical presentation. Not all patients with COVID-19 will need admission. We will have a staging area in our accident and emergency department. If you have respiratory symptoms, you're stable, and you have no fever, you can have home quarantine and self-isolation, and both the public health team at the University Hospital of the West Indies and the Ministry of Health will work on this protocol. What's our SARS management protocol? From the A&E, we will do isolation. We hope that we will be able to confirm whether you have a positive test within 12 hours. We probably, Dean, can do a bit better than that, but for now, we will say 12 hours. And the management team will include medicine, infectious diseases, pulmonary, and critical care. And all of those teams sit within the task force, but they also have a management protocol. And we've brought in all our experts within these areas. And if there's anyone that we have left out, you're invited. Our communication protocol is key. We want to discuss immediately and ensure that our environmental staff are immediately alerted, along with our Director of Nursing in A&E, who will report to our Senior Director of Nursing. And I want to acknowledge Sister Helena Thompson, who is here in the audience and who has been working hard over the last few weeks while we've been away to keep the hospital safe. We will also inform public health immediately, as well as the medical chief of staff office, who will obviously coordinate carefully with the Ministry of Health and Wellness. We've paid a lot of attention to our own staff, and a lot of plans have been made for our staff, but it's key that we look at staff protection, whichever hospital that you're at, and those, as you can see in our model here, include goggles, obviously, mask, gowns, non-sterile glove, but boots are not necessary. But the key is hand washing. Basic, highly disciplined public health measures. Hand washing, hand washing, hand washing, and use of a hand sanitizer. We have penetrated the hospital. I think we are probably close to about every 50 feet with a hand sanitizer, but there are also a lot of sinks that are around, and we will try to continue to improve that as we go ahead. We would also urge the community to continue to be vigilant and to ensure that they stay informed. We want to make sure that we're using social media and viral transmission, and we've brought our communication and public health person, Dr. Mrs. Nardia Williams-Thompson, on our team to lead that. And we have several monitors through the hospital that we will continue to disseminate information, but also training on hand washing and hygiene technique as to how to protect yourself and what to do if you become sick. The Ministry of Health has also been sharing information with us and right across the country, and I'm sure you will hear that again. We want you to wash your hands, but we don't want you to take a cursory hand washing. We want to wash your hands properly. And so we have gone across the hospital to retrain our staff on this, and I urge all hospitals, clinics, health center, but also just your organization, your banks, your facilities, wherever you are, urge your staff to pay attention to the hand washing technique. If you have to cough, we expect you to use proper etiquette in coughing. And we'd also like you to, if you are sick, to avoid contact with other people. So protect yourself, and if you have to go out because you need to seek medical attention, then we recommend a mask. But generally speaking, if you are not ill and you wear a mask, the tendency is for you to touch your face more. And if you touch your face more because there's a mask there that you're not used to, you're more likely to contract the virus. The ministry also urges you to cook your eggs and meat and to avoid, obviously, wild animals and livestock. I want to end by discussing with you this cartoon. I don't know that the numbers are necessarily correct, but it's a point of debate, and so I felt that we should discuss it. I think by tradition, we do more than a handshake in the Caribbean. We hit fists, we do thumbs, we do many different things, but this was shared with me and said, Carl, use this as a guide. If you shake hand, you may have 124 million colony-forming units. So you say, oh, well, let's do a high five. That might be 55 million. I don't know if that's true. And if you do a regular fist bump, it might be 7 million. So maybe all of us should do zero contact and ensure that we greet each other in another manner. So, let me just say that we are in uncertain times. But a great thing about the human spirit is our ability in times of crisis to innovate. In 1945, the colonies on higher education decided that they needed to train more doctors out west. They wanted more education out west. And in 1948, on these very grounds, we had our first class as a University of the West Indies. And in 1949, they started construction of the University Hospital of the West Indies. In September of 1952, we got our first patient. And in 1953, William Hugh McIntosh Foote opened the University Hospital of the West Indies at the Papine Estate in the foothills of the Blue Mountain. It's been responsible for training many of us in this room. We feel that a doctor trained at the University Hospital has touched the life of every family throughout the region of the Caribbean. And so we're confident that in times of crisis, that the over 70 years of tradition that we have gotten here at Mona, right beside the aqueduct, designed in 1758, and in this magnificent medical facility, designed in 2013, will provide answers for us as we move forward. I thank you very much.